Hi, everyone. This is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer, and I want to welcome you all to this month's Journal Club. As always, I want to thank ESGO and IGCS for their support in our Journal Club. And before we begin, also, I want to mention a few housekeeping rules relevant to this platform for today's Journal Club. We're recording today's discussion, and the recording will be made publicly available. The participants with cameras turned on may appear in the video recording, and we ask that everyone please keep your microphones muted so that we can hear the presentations and the discussion. And if you are having any difficulties or questions, please send in a chat your questions, and our technical support team will try to assist you. We definitely would want to encourage not only the questions from our fellows, but also questions from the audience as well. So we're really looking forward to this journal club. Of course, this is a special journal club because of a couple of reasons. One of them is that we have the new editor-in-chief for the International Journal of Gynecological Cancer, Dr. René Pareja, who was selected last week at ESGO in Copenhagen. So I want to
Hello.
congratulate him and of course, obviously, express how excited I am to have him take over this journal. And of course, obviously, we will give updates as to the transition onto the new editor-in-chief. So René, congratulations.
Thank you very much, Pedro, and thank you very much, everyone. I'm just excited on taking that huge task, but I'll try to do my best in order to keep your legacy, my dear.
Thank you so much, Renee. And then on to the topic of this journal club. And we're really, again, very, very excited because we feel that this topic is a very timely topic as it pertains to the field of gynecologic oncology. We are seeing over the last several years as we develop more targeted therapy, as we learn more about the strategies and the patient selection for surgeries, that overall, regardless of the disease site within gynecologic oncology, there is a movement towards de-escalating treatment. We're seeing it in cervical cancer. We notice, of course, obviously for several years now in endometrial cancer, and then also even in ovarian cancer as well. There's an overall movement for de-escalation, and thus we felt that this was a really important topic. So I do want to thank also all of the authors who submitted articles to this special issue in March of 2026 for us in the journal. We had guest editors. One of the guest editors, of course, is René Pareja from the Clínica de Oncología Astorga, Gynecologic Oncology in Bogota, Colombia. And of course, also Alex Melamed from the Massachusetts General Hospital in Boston, Massachusetts, and Gretchen Glazier from the Mayo Clinic, who unfortunately could not join us today, but Gretchen was also one of the guest editors for this special issue. So, really, very, very excited again to have a discussion about these topics. I want to encourage those in the audience to submit your questions as well, because again, I think that there's a quite a broad scope of topics that we can cover in the de-escalation of gynecologic cancer. So, with that, I want to, of course, welcome Renee, and we understand that Alex is making his way over to the Journal Club as well. He was a bit delayed in traffic, so we're gonna start with some of the questions for Renee. I want to also thank everyone, all the fellows, and everyone who has joined from all over the world, and I really appreciate you taking the time from your busy schedules, from your vacationing schedules, from your skiing, from your time at the beach, wherever you are. Thank you so much for joining as well. So with that, let's get started. And we'll turn to the first question to Nicole Chris in the University of Western Australia.
Thank you, Pedro, and thanks for the special issue. This first question is about neoadjuvant chemotherapy and cervical cancer. A key aspect to personalized therapy here would seem to be the identification of predictive biomarkers for chemosensitivity. Are there any established tumor features or biomarkers for this in this tumor stream?
Thank you very much, Nicole, for this question. At present, there are no established clinical validated tumor tissue biomarkers that can be used routinely to select cervical cancer patients for neoadjuvant chemotherapy based on chemosensitivity. Several candidates, particularly DNA repair markers such as ERCC1, have shown signals, but the evidence is still inconsistent and not standardized for a useful clinical decision making. I think the most practical personalization today comes from early responses seen in magnetic resonance imagings, and we have potential biomarkers such as ctDNA, it's dynamic during the course of the treatment disease. All of those strategies are promising, but have not been adopted as a routine management for predicting any kind of behavior, Nicole. Thank you so much.
So, Renee, as a follow-up to that question, and of course, obviously, you've published quite a lot in the setting of neoadjuvant chemotherapy for cervical cancer. Given the results of recent studies over the last 5, 10 years, with regards to a much more conservative approach, and obviously now patients being candidates for conization or simple hysterectomy when they have very early cervical cancer. As you mentioned, of the patients that have the 2 to 4 centimeters, with such great quality imaging now, I feel that we're really shifting a lot of those patients straight onto chemotherapy and radiation. So today, 2026, who is a candidate? Who would be a candidate for neoadjuvant chemotherapy with cervix cancer?
Okay, I have a pragmatic answer and I have a practical one. The pragmatic answer is we don't have enough support for giving neoadjuvant chemotherapy as a definite treatment for all the patients who don't have to preserve their womb. So Gupta and ERTC 55994 have been in negative trials. In parallel, we have a real life, the real life in Guatemala, the real life in Nicaragua, Salvador, Mozambique, when you don't have enough resources for providing radiotherapy and chemotherapy for all of your patients. So neoadjuvant chemotherapy will be still being used in many settings because they have nothing different to offer them. We need to consider that. One thing is living and treating patients in high-income countries, and another different issue is when do you have even the basic things. Regarding to your question, I think the best candidates for receiving neoadjuvant chemotherapy are just two scenarios. First is fertility preservation in patients with tumors 2 to 4. The issue is being addressed right now by Contessa trial. They have more than 30 patients. They haven't had any relapse, and probably they modified the sample size. So probably the Contessa trial accrual will end by the end of this year, and we're going to have results over the next 3 years. And the second, of course, is cervical cancer during pregnancy. And we published a beautiful manuscript led by Aldo Lopez from Peru with a series of patients, pregnant patients who underwent neoadjuvant chemotherapy in order to get enough fetal maturity and they can be mothers. For me, those are the main issues related with neoadjuvant chemotherapy in cervical cancer right now, Pedro.
Yeah. And before leaving this topic as well, when looking at what regimen to use, of course, obviously, we've seen the efficacy of the addition of immunotherapy in the setting of the locally advanced disease in the setting of recurrent disease. What indication is there? What data is there to support adding immunotherapy in the setting of neoadjuvant chemotherapy? In other words, if it works in advanced disease, why wouldn't it not work and actually provide a better response in the setting of early stage disease?
Yeah, you're right. Probably this will be true, but in the future, because we don't have yet any valid response to this question. We need to perform clinical trials, prospective ones, trying to find the role of immunotherapy as neoadjuvant strategy. We have a neoadjuvant strategy using immunotherapy, but before radiotherapy, not before surgery. At least I don't know any reference for trying to use immunotherapy in order to decrease the size of their surgery or to make the patients operable ones.
Excellent. So, if there are no further questions on neoadjuvant chemotherapy, and I'm sorry that I bombarded you with all of these neoadjuvant chemotherapy questions, but Nicole got it started, and I just took on additional questions. So thank you for fielding that. Next, we're going to go to Georgia, Leila Abulazzi.
Hi. Hello, everyone. Congratulations, Dr. René. My question is about preoperative brachytherapy. Do you use it in your centers and in which clinical situations? And if so, does post-brachytherapy reassessment influence the decision to reduce the radicality of the surgery? Thank you.
Thank you very much, Leila. This is a very, very interesting question. Unfortunately, we don't use brachytherapy in most of the parts of Latin America. Most of the literature comes from France, and they have published a lot of literature on that issue. They have even small randomized clinical trials, but most of the evidence is a retrospective one. There is a beautiful review, a systematic review and meta-analysis published by Santiago Vieira, one of my former mentees at National Cancer Institute in Colombia. We published that manuscript in our journal. And in this manuscript, you can see that even complete pathological response can be seen in up to 30% of patients. This is a huge. And also, neoadjuvant brachytherapy is associated with low recurrence rate, at least 30% less of positive margins, a better 5-year overall survival. Unfortunately, being this, most of your retrospective literature, we don't have enough information to decrease radicality if we have enough clinical or imaging responses. Those studies have been done in specialized centers, but paradoxically, those centers are located in France, in Germany, in Europe, so patients with resources. And in low-income countries, we have the patients, but we don't have brachytherapy. We don't have enough brachytherapy. So in Bolivia, there is one unit of brachytherapy working for all the country. In Nicaragua, they don't have brachytherapy. In Honduras, they don't have brachytherapy. So although quite appealing and interesting, we don't have in Latin America all the resources needed for doing this. I would love to participate in randomized clinical trials, putting Latin American patients and patients coming from low-income countries, but we need to fix first the issue related with the resources we need to go through this.
Thank you.
Yeah, thank you, Renee. And of course, obviously, it's always quite alarming to hear these lack of resources for many of these patients. For you in Colombia, what percentage of the patients that you would consider to be adequate candidates for brachytherapy actually do get brachytherapy?
Okay. In Colombia, between 60 and 70% of the patients came to us with advanced stages, and the surgical ones are the 40%. This should be used in patients with tumors greater than 3 centimeters, but smaller than 5 centimeters. This is the population. Interestingly, the current FIGO classification put these stages in different categories, less than 2, 2 to 4, and 4 to 6. But the best candidates are those with central bulky tumors without any perimetral involvement, preferably exophatic ones. That would be the ideal candidates, but we haven't tried yet because, again, we have a lot of brachytherapy resources, but those resources are being used in locally advanced cervical cancer patients.
I see. Very well. Well, excellent. Thank you so much for that. And if there are no further questions on that particular topic, then we'll turn it over to Turkey. Ilker.
You mute, Ilker. You mute.
Yeah. I'm. Do you hear me?
Yes.
Yes.
Okay. Okay. Hello, Dr. René. Thank you for everything. And about the historic perspective, according to the EMBRACE trial protocols, para-aortic irradiation is restricted to high-risk patients with common iliac involvement or bigger than or equal to 3 positive pelvic nodes. Is PET-CT-based evaluation sensitive enough to identify patients for whom elective para-aortic irradiation can be omitted? And can we use biological markers or surgical para-aortic staging to select the patients better? This question is very important in my practice because we have many patients in advanced stage also or locally advanced stage, and we always discuss this situation. If we can do para-aortic lymphadenectomy or not, we discussed this with the radiation oncologist. And years ago, I would like to do and insist on doing para-aortic lymphadenectomy, but nowadays they have enough evidence for me to I stay whatever you say for the radiation oncologist. Most of the time we omit para-aortic lymphadenectomy because they radiate very good. And what's the literature about this and your opinion? Thank you.
Ilker, thank you so much.
Ilker, I'll just say that you have hit a nerve with Dr. Pareja. The answer will probably take the next 40 minutes because I know that he's very passionate about para-aortic lymphadenectomy and has a definite opinion of para-aortic lymphadenectomy. So everybody turn off your cell phones. René,
Thank you so much.
proceed.
I want to make it short. Thank you, Iker, for your
Less than 30 minutes.
PET is excellent in detecting para-aortic metastasis, but in high-risk pelvic node positive disease, it may miss microscopic para-aortic spread. So PET negative status alone is not always sufficient to omit elective para-aortic irradiation because the false negative of the PET-CT can reach 12%. Additionally, in retrospective trials, when you use PET-CT and the pelvic nodes are positive, but the para-aortic nodes are negative, up to 30% of those patients can be upstaged. So at present, we don't have any biological marker to validate this decision. And we don't have, unfortunately, any other method because we have 2 negative trials. Uterus 11 is a negative trial on para-aortic disease. So having para-aortic nodes is a very bad thing for the patient. At the end of Uterus 11, they say that, unfortunately, they have just 4 patients for final analysis from those who had para-aortic involvement, which means that all of them, but the final analysis, have died because having para-aortic nodal involvement, having cervical cancer is deleterious and can be a mortal condition for the patient. It can be considered a systemic disease rather than a thing that we can just operate and fix everything. So we need to be careful about it. And we are eagerly expecting the results of Parola trial that will include the right population. So the patients with 3C disease without any imaging in PET evidence of having disease. And again, this is tricky because low income countries don't have any PET-CT machines. So we have all the burden of the disease, but not the resources that high income countries are suggesting us how to handle our patients. Was that enough for you, Ilker?
Yes, yes. We will discuss later and learn much more from you.
Perfect.
Thank you.
Thank you very much.
Yeah, and I would just also add that there's recent data from the United States that the rate of patients undergoing surgical para-aortic staging is exceedingly low. We typically will rely on the PET-CT, and then from there proceed with the radiotherapy. And generally, if a patient has any evidence of positive iliac lymph nodes, they're going to get extended field anyway. So the surgical staging is really not going to add much to these patients. So I see that there are several questions, and Matteo Marchetti is asking, René, do you have any parameters you use in clinical practice for choosing to extend radiotherapy to the periodic nodes.
Yeah, or guys from radiotherapy use the embrace criteria in order to give them extended field radiotherapy. One thing is that having a strict criteria, and another issue is to provide prophylactic extended field radiotherapy, because it's an issue that have been discussed heavily during the last 20 years. But we don't use to administer prophylactic extended field radiotherapy, just if there are more than 3 pelvic nodes, grossly nodal involvement, kind of bulky nodes and big disease, or having common iliac nodes that are the current indication for administering extended field radiotherapy. Again, if a patient has involvement in the para-aortic nodes, probably we can see them or we can check them through pathological analysis, but we cannot go beyond the mediastinum and the systemic disease that at the end will kill the patient if we get the opportunity.
René, is a good question here, because I think it's important to clarify this from Eric Estrada in Guatemala. He's asking, what is your opinion regarding uterus 11, that stage 2B patients were the only ones that benefited from surgical staging?
It's interesting. Thank you, Eric. When you read the manuscript in methods, they state that they don't have power to make analysis of subgroups. And at the end, in conclusions, they highlight that it could be a benefit in 2B. The uterus 11 study was not powered to make that assumption. So you can take this statement as not true, because the main issue that was oncological outcome was a negative one. So having a negative trial, you cannot start assuming that subgroup analysis can be positive, because you are overrating these outcomes, and this can lead you to have a misinterpretation of the real data.
Yeah, and I'll add to that, René. It said, and actually, I was just discussing this with our residents last night at a journal club meeting that we had, and for all of the young attendees in the audience, whenever you have a post hoc analysis, that has no meaning whatsoever clinically. It's just an observation. So basically, it's looking at your data and saying, let's just see what this data shows as it pertains to X, Y, Z question. But if it is positive, doesn't mean that really is a true fact. It's just a random finding that is there. We don't know if it's true or not. And then in order to determine if that was the case, then a properly powered study that had this many patients then would be developed. So the finding in the uterus 11 of this was just basically like saying, we look at all the data, you go to the statistician and you say, can you look and see and run the numbers and see if anything is statistically significant? Anything. I don't care what it is. Just show me. And then eventually you see a p-value that is less than 0.05. And then you say, hey, look, here's the finding. That should not be read as here's a true scientific finding that should drive our practice. Because I mean, wouldn't you think it unique that all of a sudden, for some reason, stage 2B has a benefit and then no other stage has a benefit? So again, this is only I always say, it's like findings from post hoc analyses is just for conversation. No evidence of scientific meaning.
Yeah, if a randomized clinical trial is a negative one or positive one, any other consideration, any other analysis, any post hoc things should be considered a hypothesis generator. And the level of validity they have is the same level of a conversation in a bar. That's it.
All right. So next we're going to get on to Naya Seminario from Vallebron in Spain.
Hi, everyone. Thank you, Dr. Pareja, for being here today. I'm going to change a little bit the topic. It's going to be on Sentinel node mapping in early stage ovarian cancer. And I have a couple of questions regarding this topic. The first one is, in light of the micro-ovary study findings, how should the detection of micrometastases in sentinel lymph node be integrated into therapeutic decision-making in early-stage ovarian cancer? And do you believe there is a risk of overtreatment? And my second question is that, given that patients with micrometastases in the micro-ovary study showed an excellent prognosis, do you think therapeutic escalation could be justified in this group in the medium term, or is it still premature to modify adjuvant treatment decisions based on low volume nodal disease in ovarian cancer?
Thank you, Naya, for introducing this very interesting topic. The microovary study is very interesting because it suggests that you have seen that micrometastasis detected by ultrastaging might not carry the same prognostic impact as macroscopic nodal disease. However, at this stage, micrometastasis should probably be interpreted primarily as a staging refinement rather than a trigger for treatment de-escalation. I've heard in a conference about 10 years ago, 15 years ago, that micrometastatic disease and isolated tumor cells is the way of the tumor communicating with the immune system. So even this can be just to send signals in order to activate immune responses and things like that. Probably micrometastasis and moreover isolated tumor cells are not as important as we have considered in the past. The excellent outcomes in this trial observed in the patients raise a legitimate concern about potential overtreatment if low volume disease nodal is as if automatically will lead to more aggressive adjuvant therapy. In order to make my answer short, we are in sentinel node detection in ovarian cancer just toddlers. We are not walking yet in this issue because there are many factors that can affect the outcome. So we need to refine the knowledge as we have done in ovarian, in cervical cancer and in endometrial cancer, but different to those other conditions because in cervical and endometrial, you have the cervix, a fixed structure in the midline. You have a broad variability in the anatomy of the uterovaric ligament and the infundibulopelvic pelvic ligament, the first thing to say. Second, the nodal involvement in other histologies different than high-grade serous ovarian cancer can vary broadly from close to 0 to 12-15%. So this will be an underreported issue because we never gonna get enough number of outcomes or events to address the relevance of omitting lymphadenectomy. There is also data from Santiago Vieira on the relevance of performing just unilateral pelvic lymph node dissection. I think Santiago recorded a podcast on that. There is a prospective randomized trial from Korea called LOVE study. And in LOVE study, women with high-grade, early-stage serous ovarian cancer will be randomized to undergo complete pelvic and periaortic dissection versus nothing because they already have an indication of adjuvant treatment with chemotherapy. Probably this study will solve us or will provide us enough information to redefine the real importance of the systematic pelvic and periaortic lymphadenectomy in early stage disease. So we are just looking forward to the future will bring. Thank you so much, Naya.
Yes, as an additional, thank you, Naya. As an additional comment to that, René, you mentioned the pragmatic component. We have data from patients with advanced stage ovarian cancer that high likelihood of a patient with a stage 3 or 4 ovarian cancer will have positive lymph nodes. Certainly when you look at that patient population, either micrometastases, macro, isolated tumor cells, the lymph nodes are going to be positive in that patient population. The Lions trial showed us that there is no benefit in removing in removing those lymph nodes. So it makes you wonder in early stage disease, if it doesn't make a difference in advanced stage disease, why would it make a difference in early stage disease when those patients are going to get chemotherapy anyway? And therefore, of course, obviously, then what would be the value of the removing positive lymph nodes with microscopic or isolated tumor cells?
Pedro, you're right. If I remember well, the nodal involvement rate in Lion trial was 55%, which means that 55% of ladies that didn't undergo cytoreduction already have involvement and they received chemotherapy. And the oncological outcome was the same between the groups. And additionally, there's another thing to consider that when a epithelial ovarian cancer relapse just in the nodes, you can rescue a huge amount of those patients. The problem here is the intraperitoneal relapse or carcinomatosis pattern of relapse, but you can rescue most of the nodal relapses. Despite location, even even axillary, inguinal, all of these, you can rescue them.
Excellent. So, Renee, we'll give you a break. I see that Alex has joined us, and Alex, thank you for joining us. And Alex, I should clarify when you send the message that I have been detained, you need to clarify. For most people, that means we thought you were getting arrested.
No,
So,
I was held captive by a very, very, very slow operating room team. They held me for ransom.
all right. So with that, then we'll skip Alvin. We'll give Renee a break, and then we'll get back to Renee. We'll turn to Latvia. Beate, Sarta.
Hi, my question is about early epithelial ovarian cancer. And I wanted to ask for stage 1C mucinous ovarian cancer, where you do recommend adjuvant treatment, what would make you choose a GI style regimen like Folfox or Capox instead of carboplatin and paclitaxel? And do you see that approach becoming more standard over time? Thank you.
Yeah, I mean, I think that's a great, great question. One that we argue about a lot between ourselves at MGH, where I practice. I think so my own personal practice is that I use an ovarian cancer regimen. And the reason for that is that there was a significant number of patients with mucinous ovarian cancer who were included in the early adjuvant trials. So the ACTION and the ICON trials that are now very old, but we all think of mucinous as a quote unquote rare histology, but it's not that rare in stage 1. Like when you look at stage 1 ovarian cancer, mucinous patients represent, a significant chunk, I don't know, 20%, 25, but there was a significant number of patients with mucinous cancer in those trials. And when you look at the subgroup analysis, adjuvant therapy seemed to help. And even though there were many, many regimens in those trials, the backbone of those regimens was, an ovarian cancer like backbone. So that is the reason that my standard tends to be carbotax, but I do not think it is wrong to use by any means a GI regimen. And there is certainly observational data that suggests that a GI regimen may in fact be superior, right? And especially when you mix both when you're looking at patients with advanced disease. And so I think this is going to be a very hard question to answer definitively. Adjuvant trials are rare because they have to be very large. There are no new fancy medications involved in this question that a pharmaceutical company is going to underwrite. So I think we may be waiting for a long time for a definitive study. And so I think this may be a question that is kind of institutional practice. And if we accumulate enough observational data and use some clever methods, maybe we can come up with a study that's more definitive than what we have right now. But I think both are standard of care and both are allowed.
Excellent. So we'll turn now to Giuseppe Parisi and Gemelli. And Giuseppe, your question.
So, hi everybody, thank you, Pedro, and thank you, Dr. Pareja and Dr. Melamed, for being with us today on this very interesting topic. So, my question will be on the key consideration for escalation therapy of fully mutated endometrial cancer.
So we already know that two prospective clinical trials, as PORTEC-FRAY and Rainbow Blue trial, have addressed this topic. However, the review highlight two grade zone population as the advanced stage 3 and 4 polymutated disease, and the group of immunocompromised patients, where the escalation may be reasonable, but evidence is still limited and should follow a case-by-case multidisciplinary team discussion. What is the minimum data set you would require to make a reproducible de-escalation decision in this setting? And what pre-specified safety endpoints should define an acceptable risk for safe de-escalation in these kind of subgroup patients? Thank you.
Okay, thank you. So I think we had a great podcast where we talked about a similar question, and I think that maybe I'm a dinosaur on this, but I am not. I don't, for example, for patients who have advanced stage, node positive cancer, these patients are usually have usually been treated. And so the data that we have that shows that these patients do exceptionally well, do better, let's say, than other molecular subtypes, is all, or not all, but almost all data for treated patients, right? So for me to myself, for example, not treat a stage 3 of node positive patient with POLE, I would need to see a large prospectively collected series of these patients who do not undergo treatment and see that they still have exceptional outcomes. Now, I think if you had that, right, if you showed me 100 patients like this, and there was a 1% recurrence rate, I'd say, okay, I give up. It's not the treatment that's helping. But as it is, without that kind of data set, and large 100, that's just a guess. We can argue about what size you need, but without a sufficiently precise data set in which you have a series of untreated patients, I'm not going to run that experiment in my clinical practice. To me, that is completely experimental. That has to be done on protocol. We don't know that it isn't the chemotherapy in combination with being POLE or the radiation in combination with being POLE that leads to the exceptional outcomes that we see in this population.
Great. So we'll turn over to Lucia Rivero from the European Institute of Oncology in Milan, and it actually also reflects a question that was asked by the audience. So, Lucia?
Hi all, and thank you for this special issue. My question is about avoidance of adjuvant radiotherapy in intermediate risk endometrial carcinoma. Considering three key factors such as lymph node escalation, adjuvant radiotherapy escalation, and the increasing precision and reduced toxicity of modern radiotherapy, is there truly a rationale for choosing observation upfront and reserving radiotherapy for recurrence when we face 5-year recurrence risk of 8 to 14% in the intermediate risk groups and 15 to 24% in the high intermediate risk groups as reference of the ESGO guidelines?
Yeah, I mean, I think that this is, at least in my practice, this is an area where I think, this always sounds like a cop-out, but where shared decision-making with patients is extremely, extremely important. I think that what we have to help us in this specific area is we have some very reasonable ways of estimating people's recurrence risk with various strategies, right? We know, if you trust the PORTEC calculators and other, studies like that, we can reasonably precisely say what your vaginal recurrence or your pelvic recurrence risk is with and without treatment. And we also do know that no one's ever been able to show an overall survival benefit in any study where radiation is added to chemotherapy, right? Where the control has chemotherapy and then you add radiation to it, or where you add radiation. And so I think when you share that information with patients, you say, this is what your risk is with and without. This is, I can't promise this is going to make you live any longer. I think patients fall out, or many patients will have a preference. There will be patients who will say, well, if it doesn't make me live longer, I don't want it. And there's many patients who will say, well, if it reduces the risk of the cancer coming back, I do want it, right? And so maybe it's a very American perspective, which makes medicine a little bit like choose your, a buffet or whatever. But that is very much my practice, is that I do not have, I make a joint shared decision with patients about radiation in this setting.
That's fair. Thank you.
Well, thank you, Lucia. We'll turn over to Anusha in India.
Thank you. So my question is on premenopausal patients with endometrial cancer. So as we know, mismatch repair deficient and microsatellite instability high tumors are associated with poor progestin response and higher relapse risk. So do you think it should be considered that these cases not be given the option of medical management, as 2 studies and 1 meta-analysis have mentioned that these have no or low response with high recurrence? Thank you.
Yeah, I think so. There's a small percentage of patients that do respond or seem to respond to progesterone, even if they have MMR deficiency. And so I think that I would not make a blanket rule, especially if you have a patient that's a very good candidate from the perspective of, an MRI that shows no invasion at all, and it's a small tumor, right? I think you have the runway, to give it 3 months and see what happens. I think the other area of a very, very fascinating area of investigation, I think is ripe, and that I've seen some small studies on, is there a role for fertility sparing immunotherapy in these patients, right? And I think that is a really, really interesting notion, right? That I think needs to be explored, obviously, on protocol.
Excellent. So we have just 2 more questions. Obviously, want to be respectful of your time. We'll go back to Alvin and your question for René.
Thank you very much, and congratulations, Dr. Pareja. My question is regarding de-escalation in advanced ovarian cancer. And so, given the strong perioperative benefits but lack of mature randomized trial data, should minimally invasive surgery be considered standard of care for selected patients undergoing interval debulking after neoadjuvant chemotherapy, or should its use remain restricted to clinical trials and high-volume centers?
Thank you very much, Alvin. I think this question deserves the participation also from Alex. I think it is not the standard of care. We have retrospective data, but we don't have enough high quality trials to kind of assure that will become the standard of care in those places with enough resources. Alex, can you help me a little, please, my dear?
I have no help to give you. I agree. I could not agree more with René. I think we adopted minimally invasive surgery too early without fully studying it in cervical cancer, right? We learned our lesson. And so I think if with a trial open, I think if you want to do this, do it on trial. I think we're 300 patients in to the Lance trial, a little over that. We're trying to get to just over 600, and so, if you are a high volume center that wants to do this, please join us, put your patients on the trial. But I think the standard of care today is for someone who's a candidate for open surgery, it's open surgery.
Excellent. And last question to Vincenzo and Agostino Gemelli.
Thank you. So my question is about a review article we can find in your special issue by Dr. Obermeyer. They compare sentinel node biopsy with no-nodal assessment and report inconsistent findings for morbidity outcomes such as lymphedema. And they found a paradoxically higher lymphedema rate in patients with no-nodal assessment. In the absence of a standardized definition of nodal assessment and without direct patients' reported outcomes data, how confident can we be with their results? And more broadly, now that we are so focused on patient-reported outcome and they are central to surgical de-escalation, how should we incorporate them in evaluating surgical strategies in future trials?
Okay, I'm going to address this, Vincenzo. Without the standardized definitions and prospective patient-reported outcomes, a higher lymphedema rate in the non-assessment group is far more likely due to confounding factors, contamination, and measurement bias than a true causal effect of omitting nodal assessment. To attribute causality, we would need uniform nodal strategy definitions, treatment field documentation, and prospective lymphedema and patient-reported outcomes. We don't have those yet. That's the answer for your very interesting question.
Alex, anything you want to add to that?
Oh, I just think that, I mean, I think to me this seems like when you get an outcome that really doesn't make any sense, the thing you should be asking yourself is like, what is the confounding thing that's happening that's making this happen, rather than being credulous. So to me, right away, I start coming up with hypotheses, right? Like, is it true that when we're saying nodal assessment, it may be patients who are found to have, intraoperatively suspicious nodes. So instead of a complete lymphadenectomy, they just have, the big bulky node removed. And actually what's causing the lymphedema is the combination of both the surgery and the cancer, right? And so I think that's just one potential explanation. There's going to be so many potential explanations like that I don't think that we can accept these data. I do think that to really study this, it needs to be done rigorously and prospectively in a way that Dr. Obermeyer is, one of the great experts as a proponent of randomized surgical trials.
Excellent. So, thank you both so much. This is really a great discussion. I really also want to thank you for all of the work you've done over the last several months as guest editors for this special issue. I want to encourage everyone to read the series of articles that have been published in this special issue. And once again, of course, obviously, congratulate our dear friend and colleague, René Pareja, who will be taking over this role as editor-in-chief. Congratulations, René, and we're all very happy that you will be taking on this responsibility. Excited to see what will happen with the journal moving forward. And I want to thank again all of the fellows and all of you who have joined and taken time out of your day to be part of this journal club. Thank you very much.
Thank you, guys.
René.